All right, so Bill, we're going to get started here. I'll take care of admitting other people. Everybody, thank you for joining us today with this opportunity for a presentation by Dr. William Lawson from New York City, who's professor of otolaryngology at Mount Sinai Hospital. I've known Dr. Lawson for 35 years. He was instrumental in my personal education. Because I was a resident at Mount Sinai in the mid to late 1980s. Dr. Lawson is both credentialed as an ENT surgeon and a dentist. He did his medical school at New York University in Manhattan, and he did his ENT residency at Mount Sinai Hospital. He's published over 190 articles and contributed to chapters and books and reviews. So there's really not much more to say other than it's a real pleasure to have him join us today and share a wealth of information and his personal experience and knowledge. So I will now turn this over to Dr. Lawson, and if you have any questions, please hold them till the end, and we'll have opportunity to ask at the end of this lecture. So Bill, please go ahead and, all right, Bill.
Thank you, Richard, for having me. I think the topic was chosen because your people work in many underserved areas, and repair of the ear, not for congenital, but for acquired defects, surgical, traumatic, become of importance because this is a practical problem that can be managed. I'm going to, if I can get the first slide.
Okay, Bill, we're good. We can see it. Ear reconstruction.
Get rid of this over here. Yeah. The plus and minus aspects of the ear. The first is that it's a very complex architecture, which is daunting for most people about undertaking reconstruction. The thin anterior skin is very unyielding. You can't use it to make flaps. You can't transpose it, so it's limited. Again, the presence of cartilage.
Why you need to know is now?
The presence of cartilage invites chondritis with exposure. And finally, the amount of flaps you can transpose is limited by the position of the hairline. On the positive side is that large segments of the ear they survive on very narrow pedicles. I mean, that defy your imagination. You have adjacent tissue for transfer, and there's a new vocabulary when you deal with repair of auricular defects, and which we'll discuss. Basically, when you approach the ear, you think of the central portion of the ear and the peripheral portion. The peripheral portion, obviously, is the helix, the antihelix, and the earlobe, and the central is anything adjacent to the concha, the tragus, the triangular fossa. If you separate these two entities, if you preserve the lateral portion of the ear, you maintain the integrity of the ear. And that's key because that's what has the sculpted architecture. And this is the ear, and you can see the very convoluted nature of the ear. It's elastic cartilage. You can bend the ear in half and it'll spring back. And that's a consideration in when you're working with the ear, because if you leave excessive cartilage, you're going to end up with a cup-type deformity. So look at the ear, and then look at it without its soft tissue. And a number of things are apparent. Again, the intricate architecture, the helical rim, knife edge at one point, which is very important in reconstructing. By the same token, the skin that overlies it has very little tolerance for any manipulation. And finally, the lower point by the lobule of the ear is soft tissue. Two things you never think about. Here's the helix. This is the cruce helices. This is where it attaches. This is very important in reconstruction. And the other is the quarter helices. And what happens is the end of the cartilage has a fibrous attachment over here. And so that when you want to transpose the rim, you have to relieve that, which is just a simple snip. Okay. When you repair the ear, you think of it again in two parts. The outer portion, and people talk about the upper third, the middle third, the lower third, all combined segments, and that's easy to address. And then the central portion, as I said, the concha, the triangular fossa, and the tragus. This is the new vocabulary. You can't think in terms of conventional rotation flaps.
Bill, we have a problem. I can't hear you. Can you get somebody to unmute you? Bill, could you get somebody to unmute you? Hold on for standby, folks. We're just having one small technical difficulty. Yeah, hi, Bill got muted accidentally. If you could just unmute him. You have to go next to his name and click on.
No.
Okay, there we go. Thank you.
Okay.
Thank you. Sorry for interrupting.
No problem.
Pull through flap, fold over, and tunnel. This is the workhorse. You can correct almost any auricular defect. Two other interesting things is the contracutaneous flap. Very few people know it. It's a workhorse flap because it completely reproduces the delicate architecture of the helix. And then, of course, there's the so-called mini myocutaneous flap, which is a post-auricular flap, which you'll see you can use very well to correct large central defects of the ear. Now, of course, they disconnected this. Would be nice. You know, this is becoming a nightmare. How would this get disconnected?
You see your pointer.
Your screen sharing. I don't know what the hell that means. Or should I give up?
Okay, Bill, maybe we can get your secretary. Let me call Carrie.
Well,
Just a second. Hey, Carrie, could you go help Bill? He can't maneuver the to screen it.
So what were you trying to do? Go to the next slide? All right, so let's see.
Stop the screen sharing, the advancement doesn't advance.
All right,
And
let's
my
see.
patience is wearing thin.
Share screen, okay.
Not exactly all in that order.
So where are you? You're up to here, right? This is you.
Good. Terrific.
All right.
Waiting
Can you
for the
hear us?
next. Waiting. Can you hear? No.
Yeah, we're good. We're good, Bill.
Okay.
But this doesn't advance.
All right. I've entered the waiting room.
It's not,
Right.
the slide's not advancing.
Okay, why not? You are. Why is it not advancing? Okay, use that then. See, use the mouse and do that.
Use this one?
Use the mouse. You see, I have it here.
The bottom left.
Yeah, you see it? Are you going back or forward?
Go back.
Go back, okay. That's where you are now.
Okay.
Okay.
And, okay, we'll do it sequentially. Hopefully this
Yeah,
won't
this way.
be the master fiasco.
Okay.
The helical rim is the problem because it's very thin and a very thin cartilage. And believe it or not, this is one of the procedure out of antiquity, the advanced pedicle tube flap actually applies over here. And I'll show you a case how you can literally, the preauricular skin is one of the few places you have a little working room, and you can actually create a pedicle, march the pedicle, and oversew it to the cut edge of the cartilage and reconstruct it. It sounds like a parlor trick, but it works. The workhorse flap is the combined post and retroauricular flap. Post means posterior surface of the ear, and retroauricular means mastoid skin. Okay. And so what you do with this skin is you raise it, you advance it, and you roll it over. Okay. And this is an example where you lost part of the rim, and you could be 2/3, even 3/4 of the rim. And what you do is you make an incision over here. You raise the skin off the posterior surface, off the mastoid. These are little burrows, triangles. You advance and you roll the skin over itself. I hate this thing. Okay. And this is a fairly big defect. And you take all the skin and you roll it on itself. And then you sew it, right, in place. And these are various steps. And this shows you one of the problems that you have. The problem, whether it's the ear, whether it's the lip, whether it's the nasal alar, whether it's the eyelid, whenever you join very fine structures together, you get a notch. And this is almost predictable. And as you see on both ends to some degree, when you make this flap, you make it bigger, wider than you anticipate. It doesn't matter how wide you make it, you have all that postauricular skin. And you have the excess. You can always trim that back when you defat the helix. Okay, and we'll get to this. Okay, also there's use of just pure mastoid skin. This is the tunnel method. This is a workhorse method. It sounds very mysterious, but it works very well. You can use it for acute injuries, for delayed repair. You can salvage failed replantations, as I'll show you. And the nice thing is that you can create an ear with good skin match. Okay. Here's a typical example. What you do is you take the ear and you press it against the skin. You then make an incision and freshen the skin margins anteriorly and posteriorly. You do the same in the mastoid skin, and you sew them together. And so you sew this to that and these two together. And what you've done is you've anchored the ear, and you've actually created a tunnel right there. And then what you can do is you can take a portion of cartilage, and before you close the flap, you implant the cartilage, right? So this is sewn over here. You have a space, which is your so-called tunnel. Your graft is over here. And then what you do is you incise this and you roll it over. Rolling over is a recurrent theme. That's what you roll over. Previously, we left it attached posteriorly. Now we detach it posteriorly. You roll it over. You create a new helix, 2/3, 3/4 of the helix and all, and you skin graft the donor site. The question is, where do you get the cartilage from? And you need a very thin cartilage. The only cartilage that's knife edge and preformed, like the helical rim, is the concha. You can make an incision along the junction of the concha and the antihelix, raise the skin, take the cartilage. Very quick, very simple. Some people, if you present it to them, the idea of having the scar is unacceptable. You can take it from a posterior approach. You make an incision on the posterior surface, you elevate the skin retrograde, and you take as much cartilage as you need. You see the very fine nature of the cartilage is important. So it's been implanted, it hits in place, and then what you do is you make a rollover. You make it incised over here, you roll over, it's skin graft, the defect and all, and here you have the end. And this is what I showed you before. The difference is you make a wider based flap. And so when you get contracture, we're not going to get the notching. And two, the thickness of the skin is not important because you basically at some point, you're going to have to thin it. And that's after an interval of a couple of months. What you're seeing now is venous congestion. And I'll get to this in a minute because there's a big difference between venous congestion and a flap that's, or skin pattern that's being compromised. Okay. I think the greatest thing is the avulsion of the ear. And what happens is, for whatever the reason, the ear gets avulsed and you reattach it. You should always reattach it because it makes no sense in which survive and which don't survive. Here's it a day or two later, and it's not blue. It's not plethoric. It's not congested. It's black. It's dead. Have you lost anything? Not really. So you remove the segment. This is what you're left with. You remove the soft tissue from the piece of cartilage. Again, you created your tunnel over here, right? You press it against the ear, you make incision, you sew the edges together. You took that cartilage and you implanted it under the mastoid skin, right? And then you do the rollover. You make your post-auricular and you roll it over on itself. And you've salvaged the cartilage, the architecture of the cartilage, and reconstruct the lateral portion of the ear. This is a flap that people don't use. This is like a secret weapon because what you're doing is using the helical rim to recreate the helical rim. Most people are unaware of it, and there's something intimidating about it. And basically, what you do is you're advancing the rim either superiorly, inferiorly, and you close the defect. So, cartilage excision necessary. I'm going to get to this in a minute because they have some techniques you're going to read where you don't excise the cartilage and you spend the next 2 hours trying to close the ear and with getting a bad result. The post-auricular skin is maintained intact, and then for large defects you can do double flaps. And I'll show you in a minute. You have a defect, you convert the defect into a wedge, whether it's here, anywhere along the entire length of the ear. The next thing you do is you incise the cartilage between the helix and the antihelix all the way down almost to the earlobe. And after the cartilage is incised with a Freer elevator, you elevate all the skin all the way to the inferior auditory meatus. And then what you do, once having done that, you can advance the whole thing up. In practical terms, These lesions are generally basals and small squamous cells. And the nice thing about it, you take the cartilage out, you have a complete excision. So you've removed your wedge and the cartilage. You've incised the skin and the cartilage down toward the lobe. You elevate it, right? So this is all elevated and free. I told you about the quarter helices. You take a little scissor and you snip it, and this whole flap relaxes and closes. And since it's helix and helix adjacent to each other, no notch. You know, okay. And here's the finished product. You can't duplicate this. The defect, we're talking about a centimeter and a half. What you do if you have a bigger defect? Well, it's a variation on a theme. Big defect, 2 centimeters. You do the same thing you did over here. You take your wedge is gone, or the wall segment is gone. You incise it all the way down. You elevate this, so this lower part is mobile, but you're still short. What you then do is you take the crus helicis, the thing that everybody ignores, and you detach it, right? So here it is detached, and you advance it till the two come together. And if it doesn't go initially with the scissor, you just snip any cartilage bands that are here, and they come together, the two of them. And you create a smaller but a normal-looking ear. The thing about the operation, when you're in the middle of it, it's kind of terrifying, and you say, why did I ever start it? And the answer is when the segments slide together, it's a very fulfilling experience. And another example, big defect, you see. You made your lower part, you take your wedge out, you elevated the lower part, you're going to cut the quarter helicis, which is a small snip. This is very mobile because this is all undermined. It glides up. You then detach your crus helicis and you rotate the two of them back, and they come together. And again, since it's helix to helix, you get an anatomically perfect rim. One-step procedure. You'll never notice this. For some reason, you take all this cartilage, you've transposed it to another position, and the ear looks perfectly normal. And here's the net result. The ear slightly smaller, but you have a perfect looking ear, anatomically. Now, the variation, I guess it's for very neurotic people who want to have 2 ears of exactly the same size. And so what you have to do is you basically have to steal half the size of a defect from the opposite ear. And so if you have a big defect, what you want to take a piece of cartilage from the other ear and transpose it into the bed, as I'll show you. They generally, this is a basal or a squamous, you remove this. When you remove this, you leave the posterior skin. And the reason why, anytime you use a composite graft, whether it's for the nose, you know, or for the ear, if you take a wedge-shaped graft and you want circulation from the peripheral borders, like across the edge, more often than not, it'll fail. If you leave the postauricular skin or the nasal skin, this will nourish it, and the graft will take 100% of the times. And so what you do is you harvest it from the other side, your cartilage, you close the ear, you transplant it in here, right? So now you created the 2 ears of equal size. It's a lot of work, and I would serve it mainly for people who are very neurotic, and you wonder if you should operate on them. Now there's something called the star excision. And you see it in the textbooks and all. The only thing I can say about this incision is if you ever tried it, you wish you never had. You'll spend 2 hours trying to put this together and get it not a normal but a deformed looking ear. So get rid of that from your thinking. Then there's the idea that if you have a defect, why do you want to take out a piece of cartilage so these 2 segments will advance? So what you'll do is you take out little triangles at different sides so the ear will telescope, because that's what it's actually doing. And the answer is, once you're into this operation, you wish you never had. It's the same thing. It'll take you a couple of hours to get them because you keep on removing little corners of cartilage and advancing it. And look what you end up with. You end up with a little bit of cupping, a little bit of deformity. Don't do it. If it seems radical to take out a triangle skin, once you've moved this together, it's not radical at all. You get a good ear, and this goes very quickly. I mean, once you've made your incision over here, and you incised, you undermined all the skin, it just glides up, you know. Okay. Now, I'll tell you a little something. The lower 30 years have always been very treacherous, and people don't want to undertake them. And some are traumatic, and some almost congenital defects. And what you do, a great way of correcting this defect, is you do the same thing in reverse. You want to advance all the skin and all this cartilage down to here. Well, what's preventing it? Obviously, this block of cartilage over here. You remove the block of cartilage over here, and the entire helical rim goes, and this is how you can correct traumatic or even congenital defects of the lower third. It's sort of a chondrocutaneous flap in reverse. Now, the concha is, there are several ways to take care. These are central defects. The thing about central defects, you have to resurface them. You don't want bare cartilage. You get bare cartilage, you get chondritis. Do they affect the external appearance of the ear? No. The whole external appearance of the ear has to do with the lateral portion, which is helix and antihelix. And that's why, if possible, you use chondrocutaneous flap, and if it's not, those words come back to you. Roll over, right? Flap, tunnel method. These are workhorse methods for defects that involve the greater part of the lateral segment of the ear. The post-auricular myocutaneous flap. I used to say this is the smallest myocutaneous flap. There's actually a nasalis flap, which is probably smaller. It comes from the post-auricular artery, which runs in the muscle, right? The center is the post-auricular sulcus, and you can raise skin 1.5 to 2 centimeters in all directions. You can resurface a very large defect with this flap, and of course it's one-stage reconstruction. So this is it. So you're going to remove this conchal lesion. You'd like to keep the lesions under 2 centimeters. You then outline your flap. The midpoint of the flap is the sulcus, and you just draw a circle around it, okay? Then you elevate the skin in all directions, and you're going to know because you're going to come on the post-auricular muscle, and that's going to stop you from transecting the artery. The next thing you do is you incise the skin, and you flip this anteriorly into the concha itself, and then you close the defect. And this was a squamous cell. The nice thing about taking the cartilage with these lesions, it gives you the security of knowing you have a negative margin on the deep surface. And so you have a fairly good hole. You've raised the flap on the other side, right? You incise the skin, and you just flip it into the defect, and you can suture around. You can use mainly absorbable sutures, and you can use some nylons or prolines just as anchoring sutures, so less traumatic because when you have to remove them. And this is the post-auricular surface. It's a very nice way for a defect the size of a dime or a nickel. You can do it in one stage. The other thing you can use is you, again, want to take, you can't get skin from the anterior surface here, but you can get skin from the posterior surface. And here's our old friend again, right? This is the flap, right? This is post-auricular, and this is mastoid skin, and you create a tongue of tissue. Only this time you're not using it to roll over a much longer flap, to roll over the edge of the helix, using it for a central defect. And you bring it through into the ear. Is it, again, squamous? This is a basal cell. You bring it through, the flap is here, and you sew it in place. Easy, uncomplicated. If you don't want to take any risk or something, you come in, you sew it in place. But obviously, as it comes through the ear, you need a second stage to close the fistula that you create, right? This is our own, these are our old friends again, the pull-through flap, right? There are big central defects. This is an anterior defect. These defects are very challenging, and they're very simple to repair. They're simple to repair. People don't do it. They automatically run to a skin graft, and it just makes it more complex. This is squamous cell. Here's the lesion removed. Okay. And then what you do is you take, again, the combined from the postauricular and the mastoid, you make a big long flap, and you advance it to the external auditory canal. You see it coming through over here. I'll show you this again and again. In the second stage, obviously, you cut the pedicle and you close the fistula that you created, as you see over here. Another example is same. This is a workhorse flap. It's easy and it's foolproof. It just requires 2 stages. This is the opposite. This is the postauricular flap. And what you do is with the postauricular flap, you use anterior skin. It's that simple. Posterior defect, anterior skin, anterior defect, posterior skin. So if you excise this entire defect over here, right? So you've got the postauricular skin, you've got the whole conchal bowl, the cartilage, and the retromastoid skin. You then take the ear, sort of like when you were doing in a way it is a tunnel method. You then take whatever remains of the ear and you push it back, right? You push it against the ear. This is your skin over here. And then you incise it at the posterior border of it. And I'll show you an example. Then you have the through and through, and the later stage, you cut the tunnel. And all this that has resurfaced, this is all skin from the front of the ear. So we'll do it again and again, right? Here's an example of a defect. This is up by the triangular fossa. If you want to make it simple, you just make a flap and you slip the flap through and you sew it. This doesn't, and again, you'll have to cut the tube. Another example of a big defect, right? You take all the skin from the posterior surface, pull it through, sew it in place. Close the pedicle. I want to show you a case, This is a bigger defect, and this is but it's much higher. It's not the concha. It involves the triangular fossa. And what you can do is you can move these segments of the ear with very small pedicles. So you cut this whole thing out. Then you have the concha over here, right? So you take the concha, like you would do with the helical rim, you incise it, and you rotate it up. You rotate it up, you close the bowl, and you skin graft the defect, and you have an anatomically looking ear. This is another example of an ear that is totally collapsed. So what you do, because segment was lost, the ear was sutured in place or wasn't treated at all, and this is what happens. What you do is you unscramble the ear. This is gold. This is the helical rim. You go all the way here and you mobilize it and you pull it out, right? You pull it out, and then what you do is you rotate the concha to give you the cartilage that you need over here, and then you reconstruct the whole ear. And I'll show you this in another version. The same thing. This is a triangular fossa. You cut this little button out, right? But you'll want to close it, right? And so the only way you can do the same thing. It's like a reverse contracutaneous flap, only you pull it up. So as this comes up, there's a little wedge of this you have to take off, and you always create anatomically perfect ears. It's just a little bit of planning. The central portion for the sake of Meatus stenosis. I showed you, you can take the preauricular skin, you could take a huge tube pedicle of it, swing it around, to the back of the ear. But even simpler, you make this big peninsular flap. It's wider. This you can get a lot of skin here in the in the preauricular area. You make an incision, obviously, a meatoplasty, and you rotate all the skin in the ear, and you can create a wide opening. And other examples the same way. You can use it to not just the area by the meatus, but also by the adjacent conchal bowl. This is another little parlor trick that you'll see, is that how you can reconstruct the lower part. You've lost your earlobe, right? I want to go back, actually. Yeah, the amputated earlobe. I'd like to do that. And so it's gone. And so what you do is it's the same thing. It's like the tunnel method. You lay this against the skin, you make an incision, and you sew it, right? And you sew it in place, as you've seen, okay? So it's sewed in place. Then what you do is you convert this into a bilobed flap, which sounds completely crazy, but you roll it over. The blood supply is so good. You roll it over. It's a bilobe. You flip the lobe under each other, right? Skin graft the donor. Correct the notch. In fact, again, this is probably where you should have made the lobes even wider, and you can reconstruct an absent lobule. Okay. And to make a tragus, which is very simple. What you can do is you just take the I'm going to go back a second. You just take this skin from the concha and you fold it on itself, sew it, and you skin graft the donor site. You can when you elevate this, you can take a little sliver of cartilage with you. The commonest error is you take too much cartilage and you make the tragus too bulky, you know. So the skin is relatively thin. Here's our friend again, right? The posterior defect. What are you going to do? You core it out like an apple. You lay the ear back, right? Well, just in this case, sorry, we did a simple advancement flap. Sometimes when you do this, the hairline is so close. Sometimes you can do it. You can advance it and cover the defect. And if you can't, then what you'll do is you'll core it out, and again you'll use the anterior skin. But the cautionary thing is your basic instinct is to do an advancement flap. And when you do an advancement flap, it doesn't rotate so easily, and so you always have to make it larger. And so he said, well, I'm really too close to the hairline, so what I'll do is I'll do a rotation flap, like sort of the incision you'd make for a facelift. You carry around, and you can do that. Whatever you do, make it twice as big as you thought you were going to do, because all of a sudden that skin disappears. Particularly as you're advancing skin over the parotid, it's very thick and not very pliable. Okay. So this is the algorithm, the lateral defects. These are the cosmetic deformities, right? It's a roll over, fold over tunnel. It's like a broken record you're hearing from me. And the helical rim for lesions 1 to 2 centimeters. Once you do the conjunctaneous flap, you're a believer. You never get such an anatomically perfect ear. And then for the central defects, obviously the concha, you can make the little flip-flop flap of the postauricular muscle, or you can make any one of pull-through. Depending how big the defect, how proficient you are, who you're working with, you can keep it simple, you can make it more complicated. So, 2 representative cases. So this is what you're presented with. This is a big exophytic carcinoma of the ear. So you have it, right? And you cut it out. You put a 2-prong hook here, you pull the anterior portion of the helix, see where it goes, you cut the whole thing out with the cartilage, right? Cut it out. And this is what you end up doing by the time you did it. This is the lesion, okay? So what do you have left? You got this thing over here, and you got this defect, and so what do? This is gold, the rim. You take the helical rim and you advance it to where you want it to be. This defect over here, you make again, a mastoid skin advancement flap, and you pull it forward, right, to the edge of the defect, and you sew it in place. And what you do is you always pull this to a higher level. And you'll do that when you close. Remember, this is a flap, so you have a fistula here, so that when you go to close the fistula, you make sure you tack this helix up a little higher, and you'll have a rim. This is our old friend again, the helical rim, low, right? Low on the rim. Total wedge excision, right? The skin and cartilage, right? And you pull it down, and if you're getting resistance, the lobe will come up, right? Because you've detached the quarter. You get resistance, you make a little incision over here, and you take a little block of cartilage out, and the whole thing will telescope on itself. And that's the ear. I think that's it, Richard. I'll be glad to answer any questions.
All right, does anybody open your microphone, or feel free to put a chat message in there? Does anybody have any questions for Dr. Lawson? So I'll start off at least. You know, when you try to balance the size of the ear, let's say you take the person's, they want both ears to be the same. If you're going to take a composite graft from one ear, skin and cartilage, and transplant it, is there a limit to the size of that composite graft that you can transplant from one ear to another?
Usually the cited number that's safe. Remember, you're not looking for blood supply from the edges. You're looking at blood supply from the skin at the recipient site. 2 centimeters is the usually cited number.
Okay, 2 centimeters. Okay. The other thing is, I recall that we've taken in the past, when we've had nasal alar defects, we've been able to use composite grafts from the ear as well, right, and to reconstruct the alar rim of the nostril.
Right. It's the same principle there. When you take a wedge graft, a triangular or pie-shaped graft, and you put it in, you're hoping for you're going to get enough blood supply, and the next day you're not sure if it's really blue or if it's black, and you're hoping it's blue. Then you can pie crust it with a 15 blade and get rid of the venous pressure. What you do for the nasal alar is, what you'll do is you will take skin and advance the skin so that you'll have an inner layer of skin. And when you put the pie-shaped graft in, you take, obviously, the skin off the posterior surface, you wedge it in place. This is Baker. Dan Baker has a good article on it, on the reconstruction of nasal alar defects you can look up. But what you do, you rely on the skin that you've advanced. It's literally a fold over flap of adjacent skin. You sew it in place, then you put your composite graft from the ear over it. That way your take-off approaches almost 100%. If you look at Baker's article, he has very nice pictures on how to do it.
Okay, is it possible you could send me that link or email me that, and yeah, I'll share it with everybody? The other question I have is, are there any good books that you recommend for the participants today that might be good for them to acquire, that would, help improve their reconstruction?
There's a new book that the author just sent me to review on the reconstruction of facial defects. Usually the ear is a deficient place, but he has some pretty good pictures, and I'll give you the link for that also.
Okay, perfect, great. And
the author, yeah.
No, go ahead. Okay. Any other questions? I think, Nestor, you said you unmute yourself and please join us. Nestor's from Asunción, Paraguay.
Hi, Dr. Lawson. Hi, Richard.
Good to see you.
Good to see you too. I would like to know if you have a congenital malformation of the ear, what is the age of the patient that you will start to do the reconstruction surgery?
Congenital defects you talk about? Yeah.
Yeah.
Congenital. I don't do congenital defects, and the reason why I was never trained. I never did enough cases, and I can't. I think other people have more proficiency.
Okay.
For congenital defects, yes.
Thank you.
Yeah, there's some guys up in near San Francisco that are pretty active in doing, you know, microtia surgery, you know, with cartilage implantation, and
Right.
you know, it's definitely an art. There's you know, it's a specialty within the specialty. All right. Anybody else have any questions? All right. Charles Johnson, you got any questions from Jamaica? Charles ain't answering. Okay, not a problem. Oscar, you got any questions from Ukraine? Oscar, you with us? All right, Bill, well, listen, thank you for your time this morning. I appreciate it. We'll look forward to those, that information you're gonna send. And it was, I really like it because you put together some very important flaps, especially that post-auricular flap, advancement flap that is it's definitely a workhorse for, you know, surgical repair of the auricular defects. So we'll take that into consideration.
Thank you for having me, Richard.
All right, listen, thank you very much. Thank you everybody for joining, and Bill, have a great day.
Thank you. You too.
Okay, bye-bye.